metastatic disease in the setting of non-small cell lung cancer and what we're trying to do to improve outcomes. So this story goes significantly further back in history. As I always say, as many people always say, necessity is the mother of invention and innovation. And if you look back into the 80s and 90s, when we were using standard, what we call cytotoxic chemotherapy or standard chemotherapy in terms of treating patients with metastatic non-small cell lung cancer, what we were really finding, and I think everyone would agree, that our outcomes were very mediocre. Patients would live in the range of about a year from their diagnosis, and they would mostly receive chemotherapy up front, and they would receive radiation in a variety of different forms and just for palliation, for control of pain, control of bleeding and obstructive symptoms. And so at some stage, two thought leaders in the field of oncology, Drs. Hellman and Wexelbaum, specifically around 1995, published an article where they proposed that we need to do a better job of identifying perhaps subsets of patients that actually may benefit from a different approach to our treatment. And so they, at that time, more or less coined the phrase that we use, oligometastatic non-small cell lung cancer. So just to take one step back, oligometastatic simply means a cancer that has metastasized to different parts of the body, but not throughout the body, just to a few isolated areas. And the number of isolated areas that it has spread to is still up for debate. Some people argue if it's only spread to 3 lesions or fewer. Some people argue 5 lesions or fewer. But the bottom line is it's a development of cancer that has not spread to many sites throughout the body. In fact, Dr. Wexelbaum was once in my office a few years ago because he had to come to give a talk at UT Southwestern, and I asked him that very question, what is the number? And he's like, I'm not sure either. We just felt that it represented having a few areas of metastatic deposits of disease. And so at that time, the question would become, what is this? So we've identified a subset that we want to target in terms of improving outcomes. How would we go about improving these outcomes? So we had to actually look at literature in other areas of cancer to see what their experiences are. So if you take a step back and look at patients who had oligometastatic sarcoma, maybe lesions that had gone from their primary sarcoma to just one spot in the lung, or oligometastatic colorectal cancer, where it had gone from a primary colon cancer to maybe one spot in the liver. What we started observing, and those experiences were that if you treated those sites, those distant sites of disease with an aggressive local treatment, be it surgery, which was predominantly the local treatment of use at the time, or even radiation, you actually saw an improvement in how long these patients lived. So this started giving us a signal that perhaps being aggressive with a local treatment in the form of surgery or radiation would actually not just make us feel better about trying to do something for the patients, but actually improve their survival. Furthermore, if you looked at certain patients that had cancers that spread to the brain, again, being aggressive with a local treatment in the form of surgery, or as what Dr. Mehta talked about, SRS, or the stereotactic high-dose treatment over a very limited number of treatments, actually was providing an improvement in survival in these patients where the disease had only spread to the brain. So taking both Dr. Hellman and Wexelbaum's idea of oligometastatic disease into account, and then incorporating the ideas and notions of experiences that were identified in patients with oligometastatic sarcoma or oligometastatic colorectal cancer, people in the field of radiation oncology as well as surgical oncology started thinking maybe with non-small cell lung cancer, that patients with oligometastatic disease, we may also see that kind of significant benefit. So starting from the early 2000s, a number of institutions and organizations started developing studies to try to understand whether adding a local treatment to systemic therapies would improve the outcomes of these patients. and primarily with a focus on patients with this oligometastatic non-small cell lung cancer. Now, the idea was never that we were going to replace systemic therapy with a local treatment. The idea was that these two treatments would work in synergy. The local treatment would help the systemic disease control original sites of gross disease, original sites of disease that may be bulky, and also allow the systemic therapy to continue to have an effect in killing any stray cancer cells that we could not see with current imaging. And Dr. Mehta also pointed out that over the last few decades, we've been using more and more this idea of high-dose radiation to a very focal area. This was established in the brain, of course, first and foremost, but then we started applying these same concepts to the treatment of patients with early-stage non-small cell lung cancer who could not receive surgery, which is the gold standard treatment for these early-stage cancers. So we started using these high-dose radiation in early-stage non-small cell lung cancer, saw incredible outcomes with respect to disease control. So then we were like, why do we not apply this use of high-dose radiation, what we call SBRT or SABR, in the setting of oligometastatic non-small cell lung cancer? So slowly but surely, as is the case with any new approach or new technique or new innovation, studies were done in small pockets throughout the country and throughout the world. So different institutions had different small experiences. The University of Colorado, University of Rochester, University of Chicago were some of the early thought leaders in the utilization of local treatment in the form of SBRT, or the high-dose radiation, in oligometastatic non-small cell lung cancer. And what they were finding actually was that these patients not only were treated safely, they were treated without any scalpels, non-invasively. There was very limited toxicity and side effects. And more importantly, the patients seemed to respond to the combination of the high-dose radiation with the systemic therapy. None of these studies were done in a randomized approach, and very few of these studies were done actually in what we call a prospective approach, meaning a study was specifically designed and patients were followed forward to see if the treatment intervention worked. Then around 2013, 2014, we started getting a signal that maybe this local treatment in oligometastatic non-small cell lung cancer may actually be of benefit. Our group published a paper where we took a very early study where we took just 24 patients. They all received a systemic agent. They all received SBRT. And when we looked at their outcomes in terms of overall survival, how long they lived, as well as how long they were free of disease, we found that this was very comparable to, in fact, better than some of the historical findings that we saw with patients who just received systemic agents. But the next real jump required an understanding of this local treatment in the setting of randomization. What that means is that we would do a study where half the patients would just get systemic treatment in the form of chemotherapy. The other half of patients got chemotherapy plus radiation to their oligometastatic disease. And so by doing this 50-50 direct comparison, we could actually start answering the question, is there a chance that the local treatment will actually improve the outcomes of these patients going head to head? So there were 3 studies that were initiated. One was initiated where the primary endpoint was overall survival, meaning how long do the patients live. And so that study, it's called SABR-COMET. It's another complicated acronym, but it basically was going to take longer to identify the outcomes because they were looking to see if the patients live longer. That always will take longer. There were 2 other studies done. One was a study done between MD Anderson and University of Colorado and London, Ontario program in Canada, where they basically took patients who had oligometastatic disease oligometastatic disease, and usually those patients had 3 or fewer sites of metastatic spread. These patients responded to their original chemotherapy, and then they were what we called randomized. They were assigned to one of 2 options. Some of the patients continued on chemotherapy. The others were given either radiation or surgery, in fact, to their oligometastatic disease and then continued on chemotherapy. And what this study found was that their primary endpoint was to see how long patients could go without their disease progressing, without new sites forming or without the original sites growing. And what they found was that the patients who received the local treatment had a threefold or 3 times as long progression, what we call progression-free survival, which means how long they could go without any new disease developing or any disease that was originally treated coming back. So it went from about 4.5 months to about 12 months. This was an extraordinary finding, and it certainly suggested that adding a local treatment may actually help these patients do better with respect to their tumor control. But the ultimate question is, would it translate into an improvement in how long they actually live? A second study that was a very similar model was our study that we did at UT Southwestern that was also a similar randomization. Patients started by getting chemotherapy. If they responded, they again were assigned to one of 2 arms. It's either continued chemotherapy or the other arm was radiation, and we didn't have any surgery. It was all patients who received radiation followed by chemotherapy. And again, we also found a near tripling in the time that it took for the patients that received the radiation to actually have their disease progress. So these 2 studies, I think, were the first 2 randomized efforts, which really is the gold standard, or our attempt at finding a gold standard in terms of proving that some treatment may be better than another. So we are getting very excited. Radiation may improve the lives of these patients and the survival of these patients. So as Dr. West pointed out, just as of a few weeks ago, 2 of these studies presented their data on how long patients actually live. And what these studies showed was that, and I'll talk about each of them separately. One was SABR Comet. The complicated thing about SABR Comet, it was not just non-small cell lung cancer patients. There were 18 patients with breast cancer, oligometastatic breast cancer, who were either randomized to radiation and chemotherapy or just chemotherapy alone. There were 18 prostate cancer patients that had oligometastatic disease. There were 18 non-small cell lung cancer patients. And so it was broken up. They didn't care about what the primary cancer was. They were focused on showing that local therapy improved the outcomes of oligometastatic oligometastatic cancer patients. And what their study showed was that there was indeed an improvement in overall survival with the patients that received local radiation in the form of that high-dose radiation. And the improvement in survival was actually remarkable. On average, the patients that did not receive radiation lived for about 28 months. The patients that did receive radiation lived to, on average, at least 41 months. So that kind of 13-month improvement, about a year, is unheard of, at least with the use of local therapy up till this point. So it was really an important study. Now, there are a lot of caveats to that study. Again, multiple pathologies. So you can't make any comment about its true impact on non-small cell lung cancer because there were only 18 patients or so. There was also some statistical points that made that study a little more complicated to interpret, but the overall signal was a very positive one. Now, the study that I told you that was done by MD Anderson, the University of Colorado and Canada, that compared that compared chemotherapy plus or minus radiation for non-small cell lung cancer patients only, that also showed a very significant improvement, not just in the freedom from progressing of disease, but in terms of overall survival. So those patients lived, on average, the ones who received only chemotherapy, 17 months. The ones that received chemotherapy and radiation lived 41 months on average. So again, a very remarkable increase in how long these patients are living, more than double in that study, with the aid and benefit of the local radiation. The authors of that study, and we can get into more of the details in the panel, argued that the local radiation not only helped control the disease locally, but it somehow synergized with our immune system to decrease the likelihood that it would spread elsewhere or grow elsewhere. That's up for debate, certainly. But anyway, the bottom line is we are getting more and more exciting data from these smaller, earlier studies that suggest that local treatment in the form of radiation may actually improve the survival of these patients with limited areas of metastatic disease. So the final 2 points I want to make are that these studies, I've not even mentioned once the word immunotherapy. So all of these studies were done in an era preceding immunotherapy. So now that we've seen such dramatic improvements in survival with immunotherapy, I think it does beg the question of whether, of what we will see if we combine immunotherapy with high-dose radiation or surgery. Will we see a synergy beyond what we would imagine with the combination therapy? Would we see the same results we would see if we saw it with the chemotherapy? Or will we actually see a decrease in the benefits of the local treatment because the immunotherapy is doing so well already for the patients? And so this is kind of the next generation of studies that are ongoing on a much larger scale, because I think finally we've convinced people that this is an important question so we can do larger studies. And then the other question is, you know, how many, and there are many other questions, but the two other main questions are how many lesions does represent oligometastatic disease? Should we radiate 7 sites? Would that be someone who would benefit from this local treatment approach? 15, 4, 1. We have to identify that information more clearly. And finally is the order of events. All of the studies that I've talked to you about have started with chemotherapy first, and then we added radiation. What if we added radiation up front right when the beginning of chemotherapy started, or immunotherapy? What if we only added radiation if patients failed their first-line immunotherapy or chemotherapy? These are the more subtle questions, but equally important, that we'll have to answer to address whether the idea of local treatment will truly be a game changer and become part of the standard of care for patients with oligometastatic non-small cell lung cancer. So the question that was asked is, many of these oligometastatic studies initially used what we call the progression-free survival, or the time that it takes for new disease to form or old disease to come back or to start growing again. Should that be the gold standard? Should it be overall survival? Should it be some other metric that we haven't discussed yet, such as some future types of metrics, such as some imaging that tells us that a tumor is metabolically active or not? Or should it be something like circulating DNA in the blood that tells us that there are more tumor cells around, we just can't see it by imaging? I think these are very fundamental and important questions. I think as of right now, I initially was in the agreement that progression-free survival was an appropriate endpoint, because we always would say progression-free survival will translate to overall survival. It is clearly not the case with other disease types, and that's very obvious now. I think as best as we can tell, overall survival should probably be the primary endpoint of all of these clinical studies that are looking in the setting of oligometastatic disease if we want to really make it change the standard of care. Right. So the question was, number one, going back to, again, some of these studies only included patients that had very few number of metastatic disease sites, and how prevalent is that, and how easy it is to accrue these patients to study and then to actually apply it across a broader range of patients. So, I totally agree that the study that we did that was randomized allowed for 5 or fewer Mets, and 90% had 3 or fewer. And I feel like there's a dichotomy, because Vivek Dr. Mehta may also agree with me. I see a lot of patients referred for treatment of oligometastatic disease in one setting or the other, whether it's upfront or in consolidation, whether it's at progression. And the point of the matter is, I see far fewer patients on studies than I do actually being sent over for referrals. I think part of it is because this question is so complex in some ways, in terms of how do we define eligibility of patients to studies, that we're maybe making our eligibility too narrow. By making it too narrow, we're making it more difficult to accrue more patients on the study. That certainly would perhaps dilute the end message that the study would demonstrate. But I think if we don't if we don't act fast to try to get more patients on the clinical trials to answer these questions appropriately, we'll start treating these de facto as standard of care, which I think is definitely the wrong route to take.
But I imagine that in doing these trials, it's also hard because either the referring docs or the patients will, or you guys will kind of decide it's too good an idea to randomize patients to get it or not. So there's trials, we want to get the studies done, but there's a certain element of I want what I want.
Right.
I want it.
Yeah, exactly. I happen to be the PI of a national trial, and we're having issues with accrual. Part of it was because our study did not include immunotherapy. Once it became standard of care, we were stuck with chemotherapy. Now that immunotherapy has been amended, maybe we'll see greater action. But also, a lot of these studies do what we call a 2-to-1 randomization, which means 2/3 of the patients will get the local therapy, 1/3 will get the systemic therapy alone. And that may actually spur some hopeful interest in getting the patients on the study.